Good evening, friends, and welcome on behalf of Homeopathic Journal India Foundation, IJH. Rains have come and acutes are increasing, right? There are Our OPDs are full of acute cases, upper respiratory, lower respiratory, stomachache, loose motion, and whatnot. And so we have come up with the topic homeopathic approach towards acute cases. And our speaker is Dr. Yogesh Niturkar. My memory with him is very precise person who talks minimum but gives maximum. He's He's chief associate editor at the Homeopathic Heritage. He's associate editor at International Journal of Homeopathy. He's author to 116 homeopathic articles, 116 articles. And he's book editor of Textbook of Practice of Medicine with Homeopathic Therapeutics, written by Dr. Kamal Kansar. Mind Rubrics in Homeopathic Practice by Dr. Krishna Kumar Dinde. Healing Woman with Homeopathy by Dr. Kavita Chandak. And Treasures of Homeopathic Materia Medica by Dr. Syed Ahmad. He's life member of Hamai. He's alumni of Dr. M.L. Dhavle Institute. He's PG guest, Guru Mishri Homeopathic Medical College, Shelgam, and he's lecturer, Department of Organon of Medicine and Homeopathic Philosophy at VK Homeopathic Medical College, Latur. His secretary, Samvedna's project, a multi-purpose rehabilitation and resource center for Divyang, run by RSS Janakalyan Samiti, Maharashtra Gram. His project coordinator, Chintaman Paranspe Vision Endowment for Prevention of Infant and Childhood Blindness. So that is Navjot Shishu Drishti Suraksha Kendra, Maharashtra. So welcome, Yogesh.
Thank you, ma'am.
Thank you.
So, very pleasant greetings of the day. We all are looking forward for a great weekend, and we are having a learning session at this onset of this weekend. And a warm introduction by my teacher, mentor, Dr. Nirupama Agrawal, madam. My first posting was with her. So I am very much privileged to have my introduction by my teacher. That's an honor for me. So I will start my presentation without wasting our time, so that we can cover the whole learning that I had planned to deliver, so that we can exchange a good topic. As madam had rightly said, that we are at the approach of rains. Rains are going on and there are lots of acutes. So whether the screen is visible and in full screen.
You have to make it full screen.
Yeah, it is full screen now.
Yes.
So is it visible to all?
Yes.
Okay. So my topic is homeopathic approach in acute diseases. Now, when I had given this topic, it was just that we have to select one topic and we have to relax. And when the time comes closer to present, then the question comes around what to present, because we are having so much of different types of cases, and many times over a period of time we feel that what is there in this case, because the prescriptions or the nature of cases that we go in day-to-day practice, we feel that it is very common. All of us are aware of these cases and what to present in this. So I was having this type of question, that what to present in this webinar. So whether theory of acute diseases that needs to be presented, because many students might be joining this lecture, or I should present only acute cases, or I should focus upon my area of interest in terms of research approach in acute cases. So I was just thinking about the three aspects that are related to the acute case itself. So I got an idea, and ideas are always welcome, and we need that thought process to go into that what needs to be delivered. So the first question that came to my mind as a learner, that what are acute diseases? I just went into the shoes of students, learners, and I just tried to understand that what I should know as a learner. So what are acute diseases? What are the types of acute diseases? What is the cause for acute diseases? Then how to investigate these acute diseases? Where to search for acute case taking format? Is homeopathy viable in acute cases? And how to demonstrate or how to showcase the results that we get into our practice? So the questions are very general, but they are particular in itself also, in terms of understanding the concept that we are holding and its application that we are doing in our day-to-day practice. So I just feel that we should integrate the case and concept aspect, where the learning can be maximized. We can deliver the learning in a much better way. So the first question that was there in terms of what are acute diseases, just a brief revision. Dr. Samuel Hahnemann had already mentioned about acute diseases in terms of aphorism number 72, that the general survey of diseases acute and chronic, and he has defined acute diseases in terms of these are rapid morbid processes of the abnormally deranged vital force. They are having tendency to finish their course more or less quickly, but always in a moderate time. So this is there. So then what are the different types? So these are three different types that he had mentioned in aphorism number 73, that there are individual, sporadic, and epidemic diseases. All of us are aware about the nature of these diseases, that individual diseases attack single human being. Several persons here and there are attacked in sporadic diseases, and in epidemic diseases, many persons are affected at the same time with similar sufferings and from the same cause. And these diseases are generally become infectious. So what may be the probable cause for these acute diseases? So in aphorism number 5, Hahnemann mentions about acute diseases are having a probably exciting cause. So in 73, he talks about these exciting causes as the acute miasms. And he mentioned that they are the result of transient explosion of latent sora. So I am able to relate with that. These are the way in which we can understand acute diseases in terms of its definition, in terms of its further classification and the causation. Now what next? Now cause of individual diseases. He says that excess in food, insufficient supply of heat, severe physical impression, chills, overheating, dissipation, strains, as well as physical and mental emotions. And these are because of the transient explosion of sora. This is given under the 73rd aphorism. What about the sporadic diseases? They affect only those who are susceptible to them, and the causes are, as we are aware, meteoric and telluric influences and injurious agents. What about epidemic diseases? Usually followed after wars, floods, or famine. Either ends in the spontaneous recovery or death of a patient. And here, in such cases, homeopath treats these diseases merely on the basis of symptomatology of disease. This is what Hahnemann had written in different aphorisms. Now, the next question, how to investigate acute cases? Now, the physician should content himself with the available totality of symptoms in acute cases without having any or without or irrespective of any alteration of symptoms due to other mode of treatment. Hahnemann has written this in 92 aphorism, and he said that we should provide prompt and efficient treatment with apprehension of the complete picture of the disease, and we should treat with a suitable homeopathic remedy. Now, as the nature of these diseases is of acute onset, we should give result immediately. The first dose itself should produce some sort of registration at general level, at particular level, so that we can, or the patient can have that relief instantly. Then in 99, he mentions that in acute case taking, it is easy for the patient to recall because it is of recent origin. It is fresh in the memory of patient and physician has very much less to inquire. Now, Roberts mentions that the acute cases should be recorded carefully, inquired carefully, then physician should limit. Now, many times during lecture also it is a question that what about the chronic aspect of the patient? What, whether we should ask as a part of ritual that everything has to be asked from asked to the patient. Now, it is not a something that it is a part of ritual or we should go for chronic state, except some exceptions. So after acute disease is cured, then the chronic case should be taken, as the chronic complaints should be more clear after the acute episodes. During acute episode, the chronic symptoms usually retires into the background so that we only need to prescribe to the present acute totality. Now, these are the things that we are having in our mind. Now, the next thing is where to search for a acute case taking format. Now, from where we can have these formats, which is the authentic one, and how to record or process the case. Now, there is a handbook on homeopathic case taking to prescribing written and published by Central Council of Research for Research in Homeopathy. And here we can find out that the case taking format itself is in terms of preliminary data. Then we have to interrogate chief complaint. Now, history of chief complaint and chief complaint can be combined together and inquired in that way only. Past history, personal history, then he goes for physical examination, lab investigations, going towards provisional diagnosis. The fifth part is pertaining to data processing, one of the important part after case taking, in terms of analysis of case, classification of symptoms, then the evaluation of symptoms and totality, building up a totality of symptoms where we can individualize the disease. Then the next part comes as the selection of medicine based upon two approaches, either repertorial or the non-repertorial approach. Then comes the selection of potency and dosage. Next one, prescription, general management and auxiliary measures. Then he talks about follow-up, date, change in symptoms, further advice regarding prescription, including justification, general measures and investigation. So these are the things that has been mentioned under the book on and chapter on case taking. So this is the format. So for a good view, I had just typed all the headings that are there in this format. So this is one of the standard format, recommended format that we are having. Another one is given in the science and art of homeopathic case taking. Personally, I like this format because it is very concise and it is very easy to use, where the author, Dr. Ashish Datta sir, who is also one of the learned men from the homeopathic field, who has worked for the upliftment of homeopathy, and he had been on various positions in CCRH. So the science and art of homeopathic case taking by him, where he mentions about all the ways in which or all the perspectives of different authors in terms of guidelines for case taking. In this, the case record format is there. So preliminary data, patient as a person, thermal reaction, physical findings, pathological findings, probable diagnosis, clinical indications, totality of symptoms. And there is a clear-cut guide, ailments from modality, sensation, pathology, concomitant, and choice of the remedy. And the last is the second prescription in terms of the follow-up. So this is the easy for all beginners. So we can start with this and you can enhance, or you can start with the later on you can go to the CCRH format. But this is the way that I liked very much, the case record format. Now the next question, is it viable in homeopathy in dealing acute cases? So the answer is yes. Now it is not merely saying that yes, we have results. We need to demonstrate these results based upon the guidelines, based upon the concepts that are given in the different resource books. So we will go through 3 different cases where we are going to learn how homeopathy works in acute cases. So this is a case of a 50 years old lady, RMN, homemaker residing at Latur, had complaints of initial redness, then blood clot in her right eye since 2 days. It occurred after an insect hit her eye while going on her scooty. Since then, she is having this clot. No other complaints or modalities were reported. She is a known case of DM type 2 and hypertension since 18 years. She is on allopathic medicines for her blood pressure and diabetes. She is my cousin auntie staying next to my clinic, and she showed her eye to me, and we started homeopathic treatment instantly. Thermally, she is hot. So the old investigation reports are like this. Her sugar is fasting is 160, PPBS is 230. On examination, we can see her blood pressure 150/90, and her right eye, there was a clot on subconjunctiva. So it was like this. We can see the clot. It was due to the hit by an insect, and after that redness was there and a clot formation. So after 2 days, this was the situation when she had shown it to me. So again, whether we are having any scope, let's see. Now, what is the understanding of this case in terms of diagnosis considerations, miasmatic understanding? So blood clot secondary to subconjunctival hemorrhage. Diagnosis consideration was ailments from injury due to insect hit, and local examination can see that there was a clot at subconjunctiva. The miasmatic consideration was in terms of tubercular because of the pathology, that venous system, a small microbleeding was there at subconjunctiva, hemorrhage, and the formation of clot. So I feel that it is a tubercular pathology. Now prognosis. Now prognosis is favorable. Why favorable? We can see the result, and we can understand the why I had mentioned it favorable. Hahnemann classification of disease, acute individual disease, where the susceptibility in general, vitality and sensitivity is moderate. I had used potency 200, and the repetition was frequent. Now the approach that I had selected was non-repertorial approach in terms of Boger's concept. Location, eye, right side, tissue affected, venous system and subconjunctiva. Pathology of clot formation, that is ailments from eye injury, rupture of microvascular capillaries, hemorrhage was there, extravasation of blood, natural response of formation of a clot. Now with this understanding, the prescription that I had made was of arnica. Now during our PG at Dr. M.L. Dhole Memorial Homeopathic Institute, we had seen lots of cases of injuries, and we had a full-fledged ophthalmic unit and dental unit also, where we were having a ready hand to use homeopathic medicines in cases of accidents, in cases of various types of trauma. So that learning experience helped me in coming conclusively towards arnica. So past learning is always helpful. That is one of the learning objective that we can say. Now see, this was the first thing. Then we can see the second, where we can see there are no complaints. And I had started on day 3, arnica 1M, 3 pills QDS into 3 days. And the interpretation that I had made was in terms of that arnica has acted. Earlier it was dark, now it has become pale, and we can go from 200 to 1M, so that the process of healing, cure, can be enhanced. So on 5th day, this was the situation. We can see, and after the clot was gone, I had stopped the treatment, and there was nothing to be prescribed. So yes, again we can see in acute diseases where the subconjunctiva had a blood clot, and a hypertensive patient, which is very prone for having a microvascular rupture, bleeding, and the formation of clot, because of again the secondary condition, where we can go for an ophthalmic opinion, where we obviously can find that the blood pressure, ophthalmic blood pressure, is also might be increased. So this is the first thing. This case was published in Homeopathic Heritage. You can have an access to that. So, are you ready to go for second case? I hope so. The presenting complaints were.
Yogesh, there is one question here.
Huh.
Vaishali has asked the potencies. Was there eye pain and what is the potency given?
200 potency. There was no eye pain.
There was no eye pain.
Potency was 200 because again the as there was no symptom, only the pathology was present.
Okay, these were the two questions for this case.
So we can go ahead with the second case. On 10th of June 21, GK, Miss GK, 8 years old, resident of Latur, was brought by her mother for the complaints of fever. Now in monsoon or in the period of June, viral infections are very common. So since yesterday night, patient was having high grade fever with chills, and she vomited allopathic medicine and refused to take any further medicine as there was a fever. Mother, being a paramedical staff, examined her fever on clinical thermometer and it was 102 degree Fahrenheit. She gave her tab paracetamol, and around 1 a.m. there was another episode of high grade fever measuring 103 degree Fahrenheit with chills all over the body. There was decreased thirst since the onset of fever. Now we can understand in children it is very difficult to administer allopathic medicines because of their bitter taste, and when patient has vomited allopathic medicine because of its taste or for any other pathological condition can be there, so the further refusal is very common. Everyone might have experienced this instance. As patient's father is taking homeopathic treatment for his migraine, so they felt that we should go for homeopathic treatment. Now as there was a high grade fever, we decided a precautionary measure, and it was during 21, that means during the COVID period. We felt that we should go for investigation first before starting the treatment. On examination, patient was active, no signs of weakness or dullness, but fever was still there, 102 degree Fahrenheit. Throat was not normal. Nose, there was nothing abnormality. Lymph nodes were not palpable. RS was also clear. So I just went for a routine investigation in terms of CBC, ESR, CRP, peripheral smear for malarial parasites. And after these reports, I conveyed them that we will go for a dengue test for after evaluating the CBC report. So you can see the reports here. The blood reports are normal. We can see even the PBs, the peripheral smear, blood smear for malarial parasite were tested negative. ESR was normal. C-reactive protein was also very normal. So the consideration for this was acute viral infection without having any localization. Now, if you go towards repertory with these rubrics where there are no localization, only fever is there with heat, fever with chills are there, and the general that we are able to see is thirstlessness fever during. So gelsemium, arsenic, pulsatilla were the three common remedies. And as we are able to see here, gelsemium stood first. And after Matremedica differentiation, in terms of, we can see the marking itself, there is a finer difference. But the main thing that I was able to see that the patient is very much active. And there was no sign of weakness, no dullness. So I felt that at this stage, we should go for gelsemium. So gelsemium 1 mg was given based upon the high grade fever, and I felt that there is no localization and we should go for a higher potency so that we can restrict the further progression of disease and we can reduce the fever spike also. So I advised her to report SOS, sponging, and to keep temperature chart 3 hourly. As she was a staff nurse, she was having that idea of maintaining the temperature chart. So on day 2 next day, fever was 101. Chill spikes came 2 times and was better within 20 to 30 minutes. Thirst was improved, and on fourth day there were no fever, no chills, thirst was normal, fever was normal, and patient was cured. So in such cases also, where we are going through the presentation, that is the subjective symptoms of the patient. Secondly, we are evaluating with the objective findings in terms of what the physician has observed, in terms of the activity level, in terms of the fever, and the non-pathological progression. Now, there are two different ways. In such cases, we can go with the lower potency, 30 potency, because the localization is not there. But the way in which the presentation was there, that the system was throwing that high grade fever, and the probably objective of treatment in terms of further restriction of the pathology. Because if we get, or if we lose time of 24 hours or 48 hours by giving 30 to 100, probably, as per my experience, or what other stalwarts have mentioned, in terms of that there might be have some localization also, because pathology, any pathology is having a in acute or chronic incubation period, period of progress, and period of decline. So when the disease is evolving, and if we are able to understand that the remedy is similimum, and there is only one subjective discomfort and another general symptom, so we can restrict the pathology with a more similimum and the higher potency, which will definitely yield results. And this is what we can see in this case. So that was the second case. Now let's go towards the third case.
Yogesh, there is one
Huh,
question.
huh.
What I'll do, because
Well,
it's acute, every after case I will take the question, so it will get
yeah, yeah.
added there.
Okay, okay. That
Okay?
will be easier.
Huh. Question is, patient is active with no signs of dullness. This goes against gelsemium.
Yes. But again, here, what I felt that the fever, pattern of fever. So the repertorial coverage with respect to the repertory and the number one position of gelsemium. And somewhere I felt that means we get some click, no, so gelsemium will work. At that moment, I just clicked that yes, gelsemium is having this type pattern of fever, and we can prescribe gelsemium and let's see what happens. And miraculously, means it is many times it happened that we go with a trial and error basis also. So it just clicked me. I just went to Gelsemium, and it yielded result. That was the just a casual approach at that time in terms of, because again my preferable remedy was arsenic also, pulsatilla was also there. So I felt that just go for repertorization, and it gave me a clarity that Gelsemium is the remedy, and it filtered the other two remedies. That means we are having a common practice and we come to a common remedies. So I just felt that no, we will go to Gelsemium as it is standing first. They are similar. Arsenic, Gelsemium are similar in this case with the totality. But they are, again, what I am saying in terms of the evolution of disease. So whether after the localization might be there, whether the dullness might set in upcoming hours. So every symptom was not proved on the day one of the taking. It is a evolution pattern that we have to respect. So in this case also, might be there dullness, might be there any exhaustion also. The moment the day 1, 2, 3, 4 disease progresses, there might be change in symptomatology if we are not prescribing a remedy. But if we are restricting it at the initial stages of progression or evolution of that disease, definitely it will yield results. So this was my just a general understanding at that time. Okay.
There is one more question. Any
Hmm.
viral fever would respond by 4 days. What was the role of gelsemium in this case?
So again, whether every disease has to be left out with in that pattern that it will get restored, whether it will get cured. So there is no need to go to any doctor. So in cases where we are able to see that the subjectivity is there, where the high grade fever is there, and the viral nature is also there, and the progression, and we are dealing with a scenario where COVID was predominant at that time in 21. The case is from 21. So even when we feel, or when as a doctor, when we get ill, we definitely take some medicine. We don't wait for progression of that disease. So what Gelsemium has done has shown the results. If we had not prescribed, and if we would have waited for by giving placebo, at that time it might be a research question. We can take a research question in this way also, that we will give placebo to cases where viral fever was there, and we will have a control study where we are prescribing remedies. So that can be done. That can be done. So many diseases are there, not only viral diseases which are of like headache or many other diseases, psychosomatic diseases, they will go on its own also. So whether we are ready to go into that in every case, that the physician has to decide. Gelsemium has shown results that we are able to see in terms of reducing the fever. Yes.
Those were the two questions. You can go ahead with the third case.
Okay. Now this is the third case of a 20 years girl which was investigated for her colicky abdominal pain, and colicky abdominal pain, and was diagnosed to have generalized gastritis with severe duodenitis with mesenteric lymphadenopathy. Generalized gastritis with severe duodenitis with mesenteric lymphadenopathy. Patient was having partial relief under conventional treatment from a gastroenterologist. Now, this is the chronic presentation. Patient was brought to me in her acute exacerbation of chronic complaints. So, as a pattern of evolution of disease, I started with taking how the disease has started, because the case was properly diagnosed case brought in front of me. Location we can see GIT abdomen, hypogastrium, and left lumbar region. Onset was since 2 months. Frequency was daily. Intensity we can see moderate to severe. And she had complaints of colicky type of pain with nausea. Nausea was aggravated smell or thinking of food. And she had vomiting, scanty watery inconsistency after drinking water. Now here weakness, restlessness, exhaustion, anxiety about illness, and aversion to noise company was brought in. So these were the concomitants that she had at the time of the onset, and this was since 2 months. Along with that, she had sour irritations, bitter taste, dyspepsia, appetite and hunger was decreased, thirst was decreased, stool was unsatisfactory, constipation, hard, and needs training. So these complaints were gradually increasing, and with these complaints, now she had since 2 days the acute stage. She had dull type of pain, and again nausea was there, vomiting of liquid and solid food was there, thirst and appetite was decreased, stool was normal, and the vomiting was after eating food, and along with that weakness, exhaustion, anxious feeling was there. So this was the acute presentation, and we had seen the chronic presentation also. And in this case, we are able to see that she had a past history of appendectomy 2 years back, and family history of mother having plaque psoriasis. Now these were the investigation reports where she had undergone upper GI endoscopy, and the finding was suggestive of generalized gastritis with severe duodenitis. And another thing suggestive of USG was done, where it was mesenteric lymphadenopathy was also seen. So these were the two clinical conditions that were there, diagnosed conditions, and she was in acute, and she was not in a position because of her weakness, and she was, in terms of that, she don't want to undertake any further allopathic treatment. And I had mentioned earlier that past history, the family history of psoriasis, her mother is also under homeopathic treatment. And see, whatever cases are there, most probably either fresh walk-in, and in acute stages, probably they are after failure of conventional medical treatment, they come to us, or more commonly, one of the family member is taking homeopathic treatment. That is what I had seen in my practice. Most of you might have also seen that. Now, the appetite and thirst was decreased since this illness. Since childhood, she had unsatisfactory hard stools, constipation, needs lots of training. Dreams were of frightful, she said. Menses irregular, scanty and watery flow was there. Before menses, mild abdominal pain and thermal state was of chilly. Now, why I am taking these chronic complaints? In exceptional cases, earlier I had mentioned in the slide pertaining to what Robert has mentioned, that in exceptional cases, you should go for a chronic case taking when the presentation is of acute nature. Now, the patient has been brought in front of me in acute exacerbation of chronic complaints. Patient was willing to tell the details as the evolution was needed, and my concern was in terms of understanding the constitutional remedy and the probable relationship with the acute remedy that she needs right now. Okay, so in that view, we had gone to explore the chronic complaints. She belongs to a middle class nuclear family and shares good IPR with all. Intellectually, she is very average, inclined more towards arts and crafts, made drawing many portraits of nature, imaginary world, abstract concepts, etc. She won many awards in drawing at school, college, and state level competitions. She is very much sensitive to pain and suffering of others, animals, and injustice happening to others. Since illness, she feels exhausted and had aversion to noise, company, and developed anxiety about her illness. She is having fear of unknown, bad things that may occur to about her since the illness was there. General appearance, lean, exhausted look, vitals were normal, liver spleen not palpable, left lumbar region there was tenderness. Now, as I had mentioned earlier, as per the Hahnemannian classification of disease, it is acute exacerbation of chronic complaints, fundamental miasm, psora, psychosis, family history of plaque psoriasis, past history of appendicitis, and the dominant miasm, which is rightly acting, was considered as psychosis. The understanding that was there was in terms of GIT, mucous membranes, H. pylori infection, inflammation and irritation of the abdominal mucosal lining, functional disturbance in GIT, reversible pathology. So with this understanding, the susceptibility as per the expression of disease, moderate was considered, potency was 200. Now the repetition strategy in acute cases was frequently, and in chronic it was infrequently. The approach that I had taken was of BBCR, where I tried to understand in terms of the acute remedies first, sensation and complaint, general inflammation of GIT, stomach, thirstlessness, appetite, want of, weakness, exhaustion, nausea, anxiety with, aggravation and amelioration, eating after. Arsalb, Naxomica, and the another seventh remedy of phosphorus. Now, why I had underlined phosphorus, you may come across. So the first prescription was made of Arsalb 200 pills QDS for 3 days. And when we go towards the chronic totality, the closely coming up remedies in terms of oversensitive emotional, anxiety, general disease about, fear, phobia, misfortune, noise, general aversion to, company, general aversion, artistic aptitude, frightful dreams, menses watery, and constipation. Now, these three remedies very commonly came up in terms of phosphorus, arsenic, and Naxomica, and they also stood as acute remedies. Now, all of us are aware that these are acute as well as chronic remedies. and all of them share a very close relationship with each other. Now, after studying the relationship, just revision, we all know that acute remedy, arsenic album, ars and phos are complementary to each other. They follow very well to each other, compare and similar to each other. Same way, arsalb, naxomic and phosphorus are also sharing a good relationship with each other, follows well, similar to each other. And ars and nux comparison, at the level of comparison, they are coming together. Now, remedy relationship understanding and the eliminating symptom. Now, the eliminating symptom in this case was the narration that the girl mentioned in terms of menses general, scanty, and nature was in terms of consistency was watery. So, phosphorus is the only remedy that we can find out under this, and we are able to see that the phosphorus stands first in the totality also. So it became easy for selection of the chronic remedy and the acute remedy. Now, how to record this remedy response and what follow-up analysis one has to keep in mind. Now, if you start from the first initial slides, that what kind of thinking one keeps when we are dealing with whether acute or chronic cases, there is a manner of understanding the concept and application of that concept in practice. Okay, now it is very easy to see that, share that what the remedy has done, it gets on its own cure. But again, we need to understand that a girl of 8 years having high grade fever and whether we should, and viral nature, and the probability of immunity compromise and the attack of COVID virus during that period of time. So whether it is, we can risk the life of patient in such instances. So that is also one of the thing. Many times we give placebo also, depending upon if the fever is, means patient is saying that it is 100, and we think that the disease is not progressing, we don't go for investigations also at that moment. Every till we don't go for initially in first day or second day for investigation, unless and until the scenario in front of us, what type of concomitants are there. So in this way, we try to understand the subjective distress, what kind of generals are there, whether any new symptom has been thrown up by the system, what kind of interpretation we are making at the level of susceptibility, reaction, and sensitivity, what kind of clinical thinking or disease direction we are having in that way, and the next thing in terms of action, expectations, and the reasons for deviation that we are having. Okay, so this is what it goes in the back of the mind of the physician who follows the principles, and we work as per the guidelines. So you can see the follow-up chart. I had presented this case at many platforms, and I felt that I should use this platform also to a newer crowd where we can understand the scope of homeopathy in pathologies. Now, as we had seen that ourself has been prescribed, and in this we can see that the amelioration of acute disease was there after 3 days or 4 days, and then for 2 days recurrence of acute complaints, it was reported, generals were improved, there were no new symptoms, partial satisfaction of susceptibility was there. So I felt that there needs to be repeated with increased potency, as there was initial amelioration and then the recurrence was there. Now further stimulation was done by ourselves 1 m 3 pills QDS for 3 days. Amelioration of, with expectation of amelioration of acute disease. Patient should be better within 4 to 5 months of period. This was the prognosis that I had made. What can be the reasons for deviations? Now there can be partial amelioration with return of acutes in this instance. So change in potency from 200 to 1 m, and within 1 week there was total amelioration, there was no acute, patient was improving, and she complained that there is some sort of congestion in chest. On examination there was nothing, so same clinical thinking was there, and at this moment I introduced phosphorus 200 single dose weekly with an expectation that amelioration of chronic complaint should be there. And another important objective was that the frequency of acute should be reduced. And the reason for deviation from the ourself to phosphorus was in terms of complementing the action of acute remedy by administration of constitutional remedy. So within 1 month, she had two acute episodes. Within 1 month, she had two acute episodes. Generals were better. No new symptom was there. So same clinical understanding was there. I again continued with phosphorus 200 because two episodes with such pathology is okay. So I felt that we should go calmly, not to make any, not to go fast. So phosphorus 200 single dose was given. Again, after 1 month, only one mild intensity of acute was there. Amelioration was there. Generals were totally improved. No new symptom. And again, continued with the same strategy of phosphorus 200. I had given Arsal 200, Arsal 1M in stock to take her at the time of acute. Now, after 1 month, there was report patient was not brought. There was no acute. All complaints were better. Now the patient asked for 2 months medicine. So I continued with the phosphorus 200 single dose. Now phosphorus 200 weekly single dose is acting at general and pathological level. Same 200 potency will act, and to reduce, the objective was to reduce the frequency and intensity of acute diseases. Now there was a gap after 2 months. Total 3 months of gap was there. There was no complaint, and patient was not having any medicines going on. So I also felt that we should not go for any treatment because there was no acute episode in between. Patient was better. She was doing her routine work, no abstinency from any of her duties. And my probable reappearance of acute complaints might be there. That was one of the thing that I was concerned. But here again, father was not that much in favor of taking medicines unnecessarily in the absence of symptoms. I had mentioned that you should go for investigations, but they said that we will wait as there are no symptoms. Why we should go for a scopy or go for some sort of sonography also. So again, after 3 months, subjective distress had started. Menses had become irregular, where earlier it was regular, now it has been irregular. Susceptibility and reaction pattern we can see is moderate, and relapse of chronic disease we can see in the form of acute. So phosphorus 200 again I started as where we had left earlier, and I had advised them to go for GI endoscopy, barium will follow through, and USG sonography, USG abdomen, with an expectation that all complaints will be ameliorated and what is the pathological status. So in that view, a note that we can see, patient has not consumed any single allopathic medicine during her illness. So they investigated on 10th of July 2013. You can see the date on the investigation, and another USG was done on 28th of October 2013. The barium will follow through within normal limits. Earlier we had seen that there was a severe gastritis, duodenitis was there, and mesenteric lymphadenopathy was there. And as a casual part, they had done this sonography. Now patient is totally asymptomatic, subjectively also, and at the level of objectives also. So this is what was done in these cases. So this is what we can learn from these acute management. And with this note, before questions come in, I would just like to mention a conclusive learning from a quote made by master founder of homeopathy. Homeopathy thus is a very simple form of medical practice, consistent in its principles and methods. Like the theory on which it is based, it may be seen to be complete in itself and therefore effective on its own. Integrity in theory and practice should be matter of course, with no return whatsoever to wrong ways if pride is to be taken in the reputable name of homeopathy. And the area of research is open for all. We can have lots of research work in this, probably if opportunity comes, how we can make a conclusive report of 30 acute cases or 60 acute cases. That also we can that also I can demonstrate in upcoming series if opportunity pops in. So if there are any questions, I am open and ready, willing to answer it.
So, Dr. Yogesh, in last case, there is question. Kindly explain the psychotic miasm more in this case.
Acha. So the pathologies of inflammation. Okay. Dominant miasm at the level of pathology, and we can see the fundamental miasm in terms of sora at the family level, and patient is also sensitive at that level. Also we can see the soric dominance, miasm, but at the level of pathology we can see the psychotic dimension. Okay, the pathologic aspect I had covered more in terms of domination rather than focusing upon the soric tendency of at the level of mind. So here you can see the understanding that I had at level of pathology: psychotic, GIT mucous membranes, H. pylori infection, inflammation, irritation of the abdominal mucosal lining, and the functional disturbance in GIT with the reversibility of pathology. Okay. So this was the understanding.
There is one more question. Why repeat medicine when there is amelioration setting in?
So when amelioration is setting in, the need of repetition in terms of understanding the pathology. Now there are diseases where demand initially we had repeated, and you can see the absent period of medicine also. Patient was better with medicine. Patient was improving with in terms of reduction in acute episodes also. Our objective is not only to keep patient asymptomatic, but the pathology that is ongoing in the patient that needs to be cured. So that cure will be possible if we are giving some support to the system. We have to satisfy the vacuum of the individual in terms of the susceptibility. Okay, so for that point I had prescribed, repeated, and there are certain fixed period of where we are planning that the case should resolve in 6 months, 3 months, when there are no acutes, or when there are means our intention of treatment is reduction in the frequency of acute, reduction in the intensity of the acute, reduction in the duration of the acute complaints. Okay, so all ongoing pathology also has to be giving repetition, and it was only single. I had not increased the potency. It was a single same medicine with same potency and single only with respect to the demand of the case, and it was showing its results.
Dr. Sunil is asking, how did the understanding of miasm help in the management? CR is
See, there are two
phosphorus.
parts.
CR is phosphorus, which is highly tubercular.
Yes, yes. See, there is some understanding in terms of the pathological domination of every remedy in terms of miasm also. There are lots of changes in the environment. There are lots of changes in the constitution also. Whatever provings and whatever documents are there, we are able to see results in predominantly sora cases with calcarea also. In cases of silicea, where domination of miasm is psychotic, features are psychotic, but the constitution is silicea, and the results are there. See, the overall change in environment has influencing all these things. There are some sort of understanding at the pathology level, at mind level, where we are trying to understand the individualization of patient as a person, individualization of the disease, and individualization of the remedy itself. At these levels, practically what these are tentative guides for us, where we are trying to understand that the miasms are all evolutionary. Every disease is going to start from sora, psychosis, tubercular, syphilis. This is the evolution pattern. When we are proving phosphorus or silicea or tubercular, The proving will start with showing some functional symptoms at SORA level. It will go with psychosis, and there is predominant one miasm. That doesn't mean that phosphorus is indicated in depression also. Phosphorus also commits suicide silently. We had seen cases. Calcirephos is also one of the remedy where we can see. So every remedy will have a probable array of symptoms along with the evolution of disease, along with the evolution of miasms also. But the remedy is as documented is having a predominant psychotic feature. That doesn't mean that it is not covering SORA. That doesn't mean that it doesn't cover psychosis or it doesn't cover tuberculosis or syphilis. There are cyclical relationships of remedies also. They may go in hand in combination also. For example, the patient was calcirephos in later years after over a period of time, the patient may need some other remedy also. Okay, so that we have to keep. So there are two parts. One is theoretical part and another one is practical part. And we should read provings of this so that we can understand that yes, this is the soric feature in this remedy. This is the psychotic one. Okay.
And one more
So this
thing,
is
like
my
even miasm
overall view.
understanding, if we
Hmm, hmm.
know the miasm of the case, we know how will it progress probably, like
Ah,
how much time
yes,
we have.
yes,
So everything, planning,
yes.
programming, everything depends on that. Not
Depends.
only the selection of medicine,
Yes,
but
yes.
overall planning also.
Overall
That's
plan.
why we should know what is the dominant miasm of the
Dominant
case,
maximum of the
especially
case.
in this
Yes.
type of cases, no, where
Yes.
there is a continuous chronic pathology and there are acute exacerbations. So we should
Acute
know that.
exacerbations. Yeah. So
I
already we
think
had
there are,
four questions.
yeah, there are no more questions. So thank you, Yogesh.
All my
Wonderful
pleasure.
session. You started with injury medicine to acute exacerbation. So whole
Yes.
journey of acute management you covered. Along with that, what are the sources? Like you have Organon to Roberts, then record, everything you shared in details, and that definitely helped everyone to use in practice. So thank you for wonderful presentation, and
My pleasure.
thank
Also,
you.
it is all because of MLAA Institute. It is because of NJH and now the Homeopathic Journal of India Foundation,
Yes.
Homeopathic Heritage, my Latur College, Shelgaon College, and the whole of the homeopathic fraternity from whom I am learning day by day.
So thank you, friends.
Thank you.
We'll meet again next month on third Friday of the month. Thank you and good night.
Good night.
Good
धन्यवाद.
night.